Hi, everyone. Welcome to day 2 of the G-WAC One Health short course. As most of us were here yesterday, we got the knowledge and understanding that this is the maiden edition of the short course organized by G-WAC. Yesterday's presentation took a turn into the evolution of the concept of One Health and also understanding some underpinning concepts and issues, how the course has evolved or the concept of One Health has evolved over time. We had the presentations from Professor Walter Bruchhausen and Dr. John Amoesi. And today, we are looking at health systems resilience as one of the very principal pillars of One Health. To do this for us, we have two great experts in the person of Dr. Wilm Quentin, and later on, we will have Professor Reinhard Busse also giving us a presentation. The two presentations have been well organized to give us a brief or understanding of health systems and how to improve and strengthen health systems against shocks. Dr. Wilm Quentin, who will begin the presentation, is a medical doctor by training and a political scientist as well, and then a health systems expert of many years standing, over decades, years of experience. He has consulted for international bodies like the WHO and other regional bodies, also for the European region or OECD countries, and also the African WHO in terms of Afro as we know it. He's also consulted for many countries, the Belgian government, and currently he has a number of projects in Ghana, all in the area of health systems research and management, or policies, as some titles. Dr. Wilm Quentin, thank you very much for your time, and you may have the podium for your presentation.
Thank you very much, Daniel, for the introduction. I'm very happy and honored to be invited to speak here in this One Health short course on health systems resilience, concepts and strategies. And as you have heard yesterday, more backgrounds on One Health, we are focusing more on as the pillars of resilience are for prevention and pandemic the concept of the German West African Center for Global Health and Pandemic Prevention. Resilience is an important topic that has gained increasing attention over years. I want to start my presentation here with a brief overview of the publications that are listed in PubMed, so the largest database on the term resilience. And as you can see, the PubMed has 6,000 publications on resilience, but most of them have really appeared very recently. Until 2000, there was 100 per year. Now, since the year 2000, and increasingly since the late 2015, 2016, 17, 18, 19, 21, 2, the number has really increased exponentially. And so there's now a really high rate of publications on health, on resilience per year. But as the concept is still relatively new and has been transformed and integrated into the health literature coming originally from other areas, the concept is still evolving, and there are differences in the terms, in connotations of what is really meant with the term of health system resilience and of resilience in the health literature. And so there have been attempts to bring together these different approaches and understandings of resilience in different frameworks, and I will introduce some of these in the next few minutes. But health system resilience is not only an academic term and used for analysis, but it is also a practical term, and there have been attempts. This is a paper by one of the leaders of the health systems unit of the WHO, Afro health systems, and an exploration and attempt to assess health system resilience in the African region. And health system resilience has been increased also by international organizations that provided to improve health system resilience. And reports that the expert on the funds that European learned from the COVID-19 pandemic. And very recently, there have been also by the World Bank published on that change cannot wait, and that it is important to build resilient health systems in the shadow of COVID-19 in order to prevent the next pandemic, to prevent and to address the next pandemic. For my presentation today, I want to focus first on what a health system is, because what is resilience can really, or what is health system resilience can really be understood only if one first introduces the concept of what a health system is. Before I go into the question of how to improve resilience and addressing how resilience is related to the concept of One Health and whether One Health can contribute to resilience or whether resilience is necessary for One Health. But I want to start with the question of what is a health system, and if this was an in-person class, which this unfortunately is not, I would ask you to tell me and to think about what a health system is. And maybe you can try to think about it for just a moment before I give you the definition of what a health system is. A health system are all the people, institutions, and resources arranged together in accordance with established policies. And the policies are important because they are the ones that turn the people, institutions, and resources into a system, and that is functioning in a certain way, and that is doing certain things in order to achieve its aims. And these aims are to improve the health of the population they serve while responding to people's legitimate expectations and protecting them against the costs of ill health. And while the first goal to improve the health of the population is more or less self-evident, the other two are also really important goals of health systems: to respond to people's legitimate expectations, because people expect health systems to respond to their needs, also to their non-medical needs, in terms of being respected and treated with respect when they visit a health system, and that facilities are not dirty and comfortable, and that they also protect them against the costs of ill health. And that is really what makes the system, that it provides the resources and assures that people can access healthcare services without feeling the financial burden of ill health. And the last part of the definition is that the system exists through a variety of activities whose primary intent is to improve health. And while this may appear like a duplication of the first aim of the system, this part of the definition is important because it describes the boundaries of what the health system is, that it includes only those activities whose primary intent it is to improve health. And this is probably important also in the context of One, where it's more evident that there are important aspects that influence the health of the population that directly improve the health of the people. Then we think of environmental health, but other examples are also education of people, which is an important contributor to improved health, or housing conditions, food and nutrition conditions that are important conditions to improving the health of the population, but whose primary intent is not to improve health. And therefore, they usually fall outside of the health system. And health systems have been conceptualized through a range of different frameworks, but a particularly important framework that has been used for more than 15 years by the World Health Organization, but also by many academic and other organizations, is this building blocks framework that was published by the World Health Organization in 2007 in a report that was called Strengthening Health Systems to Improve Health Outcomes. And this framework conceptualizes health systems in the form of 6 interrelated building blocks, starting with leadership governance as the basic foundation for a health system, continuing with financing, the resources, the financial resources that are necessary to fund healthcare provision and to make available medical products, vaccines, and technologies, the information system that is needed to govern the health system, to assure that the financial flows, the financial means are used in a way that are appropriate for the healthcare system, and to monitor the overall performance of the system, the health workforce as an essential building block and the necessary requirement in order to deliver services, and finally the service delivery function of the health system as the most visible function and the direct where most are interacting with the health system. And these building blocks, while they are here conceptualized as blocks, should not really be thought of as building blocks, but rather as interrelated aspects of one system, which is functioning as a complex and adaptive system where there are many interrelations between the building blocks. And these interrelations are what turns the individual building blocks into a system, because changes in, for example, in leadership governance have an impact on financing. Changes in the payment of health workforce will also affect the changes in service delivery. And so the actors working within the different building blocks make sense of what is happening in the system and of the incentives that are applied to them, and then behave in a certain way, which sometimes has unintended consequences. Nevertheless, the entire system functions to achieve, on the one hand, intermediate goals, outcomes, which are access, coverage, and quality and safety. And together, these contribute to the overall goals of health systems, which include improved health, which is important not only at the average level, but also the distributional level, the equity of health in the population, responsiveness, where again, the overall average level is relevant, but also the equity, the distribution of responsiveness in the system, the social and financial risk protection, and improved efficiency. So these goals are the ones that were already mentioned in the definition of the health system, plus adding the goal of improved efficiency, which is important because resources should always be used efficiently in order to make sure that the maximum level of health, responsiveness, and social financial risk protection can be achieved given the available resources. Now, after this brief introduction to health systems, I want to come to the concept of resilience, the origins and its relevance. The origins of the concept are in fact in environmental sciences, engineering, psychology, and resilience has only relatively recently moved into the health systems literature and the public health literature. In engineering, it was more related to how certain materials behave to shocks or external pressures. In environmental sciences, it was, for example, related to how forests react to droughts. And in psychology, it is related to how people mentally react certain stressors. Surprisingly, there's a very wide variation in the utilization of the term in the health literature, although maybe it's also not that surprising given that the term has been in literature only relatively. In some cases, resilience is used to talk about health systems responses or the capacity of health systems to respond to sudden shocks, whereas other definitions and terms refer more to responses to not only sudden shocks, but also more long-term crises or structural changes that affect health systems. Sometimes the term is used more narrowly, focusing on crisis preparation, response, and recovery, while other definitions take a broader focus, including also anticipation of crisis or shocks and or the growth after crisis and recovery. In addition, definitions differ in terms of whether or not what strategies they recognize as a strategy during the response to the shock, whether they only focus on absorption or whether they also include adaptation and or transformation of the health system as part of the concept of resilience. Finally, there seems to be confusion whether resilience is in fact an attribute of the system, so whether a health system is resilient, whether it is an outcome of the health system, so whether the health system contributes to resilience, or whether it is a mediator variable that contributes to a health system achieving its outcomes because it is a resilient system. And I want to give you now a few examples of definitions. Narrow definition, which was the one that has been published and promoted here in this policy brief published by colleagues of the European Observatory, that says we define resilience as the ability to prepare for, manage, that includes absorb, adapt, and transform, and learn from shocks. And this is one definition that focuses really on health systems' ability to prepare for, manage, and learn from more sudden shocks, whereas this report of the EU expert group on health system performance assessment and also other reports by the Organization for Economic Cooperation and Development and the approach of the WHO Afro region focus not only on sudden shocks, but also more on structural changes. And there, the definition is that a health system resilience describes the capacity of a health system. So here, the definition focuses more really on the capacity, the ability of the system to, so it's an attribute of the system to proactively foresee, absorb, and adapt. So these are parts of a cycle to a crisis or to a shock, and not only to a shock, but also to structural changes in a way that allows it to sustain required operations, resume optimal performance as quickly as possible, transform its structures and functions to strengthen the system, and possibly, ideally, to reduce its vulnerability to similar shocks and structural changes in the future. And inherently relate to this concept of resilience in many definitions are different stages or conceptualizations of what a shock or disruption is. And these are usually conceptualized in terms of a cycle. The first stage of this cycle is often termed preparedness of health systems to shocks. The second stage is shock onset and alert. The third stage is shock impact and management. And the fourth stage is recovery and learning. And looking at the first stage, it is important to assess how vulnerable a system is to disturbances and to prepare the system to be less vulnerable to a potential shock. With regard to the second stage, the focus is on timely identification of shock onset and types, in particular in relation to One Health. It's related to surveillance systems and diagnostic capacity to early detect shocks. In the third stage, it's about how a system absorbs a shock. So, and with absorption, it's usually meant that the system can continue to function more or less as normal, despite being exposed to this stressor, to the shock that comes from the outside. But potentially, it may have to adapt to the shock, and adaptation means that it will have to reallocate resources in order to still function, or it may repurpose certain buildings, or it may, for a certain amount of time, do things differently. While transforming is the last option to respond to the shock, and in order to manage to assure the functionality of the system, means to structurally change, to transform the system to ensure that it can still achieve the goal. So to really repurpose, to do things very differently, and using different capacities of the system, which may potentially also continue to be used differently after the end of the shock. And this then turns to the recovery and learning, to some kind that the system will return to some kind of normality, but that changes may persist even after the end of the shock. And ideally, the system will come out stronger and learn from the shock, and may even from transformation, if there is transformation happening, may incorporate those parts of the transformation into the normal state that are beneficial for the overall performance of the system. And how the system change and disruption cycle is in fact related to health system performance is illustrated in this graph, where these shock cycles or disruption cycle stages are illustrated here on the lower end of the graph, and they are called here prepare, absorb, recover, adapt. And the idea here is that during the preparation, the focus would be on minimizing disruption during absorb and recovery period. Once there's an onset of the disruption, the health system performance is likely to reduce. Then after certain will recover again after certain changes, and it will then become the adaptation phase. It may even improve performance during the adaptation phase to come to levels that are higher than before onset of the disruption. In one of my first slides, I already said that there has been the attempt to bring together, to develop a meta-analytical framework of resilience. And there's Foroughi et al. They tried to bring together the different concepts, and they in fact identified 5 stages of resilience, with the first stage being anticipation, which is related to the vulnerability of a system, following risk analysis, potential shock. The second stage or phase is preparation, to improve essential capacities, establish governance structures, performing planning activities, and doing legal preparations to put in place laws that will allow to react during a certain shock. The third phase is the response phase, where the system will have to react to changing circumstances, and it will involve all system blocks. And the ability of the system to respond to the shock depends on anticipation and preparation. The fourth phase is recovery, which relates to reducing performance deterioration. And there the question is, to which level can the system recover, and how quickly can it recover after the shock? And the recovery phase really has to take a long-term view. And the final phase is the growth phase, where health systems should improve and change as a result of learning from the shock to become more resilient in preparation for future shocks. Now, turning from the concepts of health system resilience, which highlights that it is related to, in many definitions and concepts, to the response of a health system to a shock, and that this response happens in phases, through anticipation, preparation, responding, recovering, and growing. Sometimes also resilience may refer to more long-term adaptations and changes of systems to these long-term systems, although I would rather I prefer the definition that really focuses on the response of health systems to sudden shocks and the recovery and growth after shocks. I would like to now turn, after this discussion of the conceptual issues of health system resilience, to the characteristics of resilient health systems and how to strengthen resilience of health systems. And there, different reports that I have already shown at the beginning of the presentation, they have outlined some aspects of characteristics of what resilient health systems are. So this is based on the report by the World Bank on Change Cannot Wait, Building Resilient Health Systems in the Shadow of COVID-19, which says that resilient health systems are aware, they recognize population health needs and risk drivers and detect threats and map strengths and weaknesses. They are agile, they are able to respond to evidence and changing needs and uncertainty. They are absorptive, they are able to manage crises, to maintain core functions despite the need for distribution of resources. They are adaptive, they are able to minimize disruptions and maintain essential individual services despite changes in resources. They may be even innovative and reorganize structures and operations based on lessons learned during a crisis. They are integrating essential public health functions with individual and clinical services, and they are They are working multi-sectorally. They are coordinating and drawing value from partnerships to implement resilience-sensitive and specific interventions with other disciplines, environmental and animal health, by taking a One Health approach and beyond the health sector. And these strategies to strengthen resilience can in fact be mapped to different health system functions and the different stages of a shock cycle. And while there are some of these strategies to strengthen resilience, they are relevant to all stages of a shock cycle, there are other strategies that are particularly relevant to certain aspects of shock. And while some strategies are in fact important in always to strengthen health systems, others are really particularly relevant for strengthening resilience and for improving their ability to respond to shocks. So with regard to governance, for example, effective and participatory leadership with a strong vision and communication are important. Coordination of activities across government and key stakeholders is always important. With regard to shock onset and then the other stages of the shock cycle, organizational learning culture that is responsive to the crisis is important. And surveillance and enabling timely detection of shocks and their impact is particularly important during shock onset and alert. I don't want to go through all of these, during shock impact and management, ensuring the stability of health system funding through counter-cyclical health financing mechanisms and reserves is important, and the flexibility that systems have to reallocate funding to meet changing needs is also important, and health systems should put in place approaches to make sure that they have flexibility to reallocate funding due to changes to be able to change funding to meet changing needs. In addition, for concerning resources, an appropriate level and distribution of human and physical resources is important always, but in particular in order to be able to respond to certain shocks. And during the shock impact and management, the ability to increase capacity to cope with a sudden surge in demand, so-called surge capacity, is particularly important. Finally, for service delivery function, in particular, alternative and flexible approaches to deliver care are a key attribute of resilient health systems, that they are able to reorganize and deliver services differently in the case of shock. In addition, there are further aspects, further recommendations how to strengthen resilience, but I don't want to go through all of them. Maybe I'll try to highlight a few with regard to governance, partnerships. Partnerships are also related to governance in a certain way, thinking of the building blocks framework, that it is important to have appropriate preparedness plans in place, that there are whole institutionalized whole of government approaches with regard to financing resilient health systems. It's important that it's possible to ring fence and track investments in pandemic prevention and preparedness and response, that there are agile and crisis-ready financing mechanisms, this flexibility in the use of funding with regard to human resources, that first there's an overview of what resources are available, that there is a diversified human resource capacity that can be deployed flexibly depending on current needs, that the system supports. So this more innovation to the information building block innovation and health intelligence, which are important to strengthen in particular early warning, surveillance and epidemic intelligence functions, and to strengthen interconnected laboratory capacity and regional networks to make sure that information is transmitted to where it is needed to take decisions. With regard to health service delivery, it is important to develop plans for continuity already before a shock happens. Communication and community engagement are important to make sure that that there are channels to communicate with the population and to have two-way communication channels and to empower communities by involving them in decision making. And finally, to have crisis-ready supply chains that are resilient and not affected by suddenly by shocks. Now, having gone through all of these strategies how to improve resilience, you may wonder how this is in fact related to One Health. And I want to, in this last part of my presentation, I want to link to my resilience related to One Health, starting with the efficient story introduced to speakers yesterday, which is the One Health definition by the One Health high-level expert panel, which conceptualizes One Health as an integrated and unifying approach that aims to sustainably balance and optimize the health of people, animals, and ecosystems, recognizing that the health of humans, domestic and wild animals, plants, and the wider environment are closely linked and interdependent, and mobilizing multiple sectors, disciplines, and communities to address threats that originate at the interface between animals, plants, and the wider environment and humans. And why is there so much attention on One Health approaches, but also on resilience at the moment? Of course, this is related to to us being in the aftermath of the pandemic, and as termed here in this report by the World Bank, that One Health is the approach that will enable us to put pandemics behind us. And the argument that was already suggested is that many emerging infectious diseases have the pace of emerging infectious diseases has accelerated, and that pandemic risk can be reduced at the source by addressing the drivers at the human-animal ecosystem interface, and therefore One Health is the necessary foundation for health security and pandemic prevention. Therefore, One Health approaches can reduce the risk of future shocks, and the shocks are what health systems have to respond to and why health systems have to be resilient. So by taking One Health approaches, one can reduce the risk of future shocks and potentially either eliminate these shocks or make sure that the shocks are responded to early enough to avoid that they have a severe impact on the health system. And these are approaches that are promoted by the World Bank and supported by big financial investments that are channeled by the World Bank to support, or at least there's the plan to support the strengthening of animal health and veterinary services, to improve on-farm biosecurity, to reduce deforestation, and to improve urban planning to address the drivers of disease emergence. And on the one other hand, to take One Health approaches to laboratory diagnostic epidemiological investigation, and then to make sure that the health system is resilient in the face of healthcare surge capacity, vaccine and therapeutic development, and management of long-term impacts. And as you can see here in this report, which really focuses on One Health, it also has kind of this idea of different cycles: preventing, emergency event, detecting, responding, recovering, which is relatively similar to this idea of the cycle, the shock cycle, that is part of the concept of resilience. There has been quite some research, and this is a very recent paper published in the Lancet on the strength of evidence of the potential of One Health approaches to respond to global hazards, so to respond to emerging infections. And there's minimal evidence that One Health approaches are effective for prevention, preparedness, detection, and surveillance measures. For other relevant aspects, there is realization that risks and hazards to global health security can also be improved through prevention, preparedness, detection, and surveillance measures. And I don't want to go through all of these, but what this shows, bringing it together, is that One Health concepts are particularly important during the early phases of shock, for anticipation, preparation, while they are less important for responding, and they become more important again during the recovery and growth part of shock. Now, finally, how to improve health system resilience through One Health approaches. On the one hand, relate to leadership and governance. One Health strategies, cooperation between ministries, and building partnerships is important. Financing, ring-fencing budgets for One Health actions is important. One Health approaches for laboratory diagnostics should be supported. It is needed to integrate One Health surveillance systems, data sharing between ministries, and having joint health risk assessments to strengthen the One Health workforce to be deployed flexibly in case of shocks, and to build One Health capacity to be used flexibly in case of shocks. This brings me to the end, that health systems are people, institutions, together in accordance with established policies. Health systems refers to the ability to prepare for, manage, or adapt to shocks. Resilience can be strengthened by improving health system building blocks, clarifying roles, ring-fencing budgets, diversifying supply chains, improving surveillance, strengthening workforce capacity, and service delivery. And One Health approaches are key for global health security and pandemic prevention, and One Health approaches can contribute to greater resilience of health systems. Thank you very much for your attention. And with that, I hand back to the moderators. Hello?
Hello, everybody. Thank you very much, Wilm, for your interesting introduction presentation. And I'm now very happy to introduce our next speaker, who is Professor Reinhard Busse. And it is not easy to introduce him shortly because his CV is quite long, but I will try my very best to keep it short as possible. So Professor Reinhard Busse is the department's head for healthcare management at the Faculty of Economics and Management at the Technische Universität Berlin, the Technical University Berlin. He is also a faculty member of the Charité, Berlin's medical faculty, and he is the co-director and head of the Berlin hub of the European Observatory on Health Systems and Policies. And he is also a member of several different scientific advisory boards, as well as a regular consultant for the WHO, the European Commission, the World Bank, OECD, and other international organizations within Europe and beyond. He has already been the dean of this faculty, and his research focus is very varied. So he focuses on methods and contents of comparative health system analysis and assessment, as well as health service research, where he has an emphasis on hospitals, human resources, cross-border care, health reforms in Germany, the role of the EU, financing and payment mechanisms, as well as disease management. And moreover, his focus is on health economics and health technology assessment. He is also a lecturer of various different teaching courses at the TU, but also at the KNUST in Ghana. And this might be interesting for some of you. Professor Busse is the director of the annual Observatory Summer School, which takes place in Venice. And it covers a wide range of topics, from technology assessment or the aging crisis performance assessment and innovative ways of improving population health. And some of you might know Health Policy, where Professor Busse has been editor-in-chief since 2011 and now handed it over to Wilm Quentin. And I think I will stop here, because if I go on, there will be so much more to say. And I'm happy now to hand over to Professor Busse.
Yes, welcome everybody. Thanks for these nice introductory words. And I have been asked to address the topic of how we can identify diseases, prioritize them from a health system perspective. And this is what I want to try to do, especially alerting us all of available data, but also of concepts. And I think both things cannot be overstressed, that we need a good conceptualized view of the world, of what we want to achieve, and we need to know where the data are. And with that, I want to share my slide here. So I hope this works here. So the topic is criteria for disease prioritization, a health system perspective. And if you remember what you have already seen on the right-hand side here, a picture of the One Health system, which you have seen yesterday. And we are now clearly in the ecosystem health with healthcare. I'm a healthcare specialist, health system specialist, but clearly with this broader view on public health, One Health, planetary health. And it's important to see at these issues together. But today, or in my presentation, we focus on the health system. And Wilm has already given us a short introduction of the definition of health systems, of the building blocks, and of the intermediate goals and the overall goals. And I will base my presentation on that one, starting with a apparently very complex looking framework on the next graph, which I will take you through. So when we look at health systems, important aspects, and these are these three big blocks here on the lower side of the graph, and they were parts of the intermediary or final objectives in the definition, which Wilm has shown you. So a good health system needs to be accessible for the population. And I cannot go into details of how we assess performance today, but it's clearly a necessary prerequisite if we want to identify priorities, we also need to have a good health system in place which can actually do something about these diseases. And so the first big performance dimension, as we would say, is accessibility, marked here as step 3A. And for those people who are able, or who we as health system people in ministries, national health insurance authorities, and so on, so where we can make sure that they reach a health system, a health provider. I will say a few more words a bit later. Then the second step for those who reach health services is the quality for those who receive services. And together, people who reach health services get good quality. We can then concentrate on measuring the contribution of the health system to population health outcomes and also to the responsiveness, which I don't want to mention today. But often policymakers then think it's accessibility is key, but we also, and these are the steps 1 and 2. Above the accessibility, we need to make sure that we have a clear view of for what conditions or patients with what diseases can really benefit from a health system. Too often, also among the medical profession, and I'm a medical doctor myself, that we think that people who are very ill, possibly close to death, that they have a larger need for health services. But from a health system perspective, it's clear to disentangle and say people with need are those where the health system has something to offer. So where the health system, healthcare is suited to change the course of the patient to the better. This is what we say here in this graph. So the condition is amenable to healthcare. If the patient gets health services, and if these health services are of good quality, then his or her condition will improve. While there are other diseases, possibly because we do not yet have treatment, which do not constitute need. And the healthcare need is...
Professor Busse, I'm sorry. Can you share your full screen, please?
I'm trying to do this. What do you see? What do you see on your screen?
Before we just saw all the slides, so not in presentation mode.
But now?
Now we see only the two of us. We need to do it as we... you should go into the reading mode, please. As we did in the afternoon.
What do you mean the reading mode? Frau Stuckmann, was meinen Sie? I'm sharing my slide. Is this not correct?
Nee, davor war es so, dass man die einzelnen Slides sehen konnte, nicht die, nicht die große
Wie haben wir das denn gemacht?
Ich glaube, Sie müssen einfach oben nochmal auf ganze Bildschirmpräsentation gehen. Bildschirmpräsentation und dann jetzt starten. Ansonsten machen Sie einfach so weiter, dann ist es auch egal.
Nee, wo soll ich da drauf gehen? Ich weiß es nicht. Ich weiß wirklich nicht, wo ich da drauf gehen soll.
Also normalerweise können Sie das so machen, wenn Sie oben auf Bildschirmpräsentation klicken und dann von Beginn an, da müsste eigentlich die ganze Folie erscheinen.
Okay, we try again here. So this is... Sorry, what do you see now? Frau Stockmann, what do you see now?
Now it's loading. Now we see it as we have seen it before. So not in the entire presentation mode.
The technician, can you please help me? Hello.
The technician is always saying go into reading mode.
Yeah, what is
Also,
reading
Sie
mode?
müssen
What is
den
reading?
ganzen, you need to share the full screen.
Das
You
mache
can
ich
do
doch,
this
Mensch.
downwards to
Mach
click
ich
on
doch.
this button down. Oder Sie gehen auf Bildschirmpräsentation und dann von Anfang an.
Ja, das mache ich doch.
Oben
Ja,
Bildschirmpräsentation,
that's what I'm doing.
ab aktueller Folie und dann müsste eigentlich die ganze erscheinen.
What? Now I'm in the presentation mode from the beginning here, and I'm now in my framework with these 3 blocks. You don't see that?
No.
Shit. Okay. Just a second, please. Just a second. That's a disaster. Okay, we now try the other one here.
Vollständiger Bildschirm teilen gehen, wenn Sie oben
We will continue shortly. I'm very sorry for these technical problems, but we try to share the full screen now in order to increase the readability of the slides. Now we go ahead. Now we can see the full screen. Now we cannot hear Reinhard Busse.
Can you hear me now?
Yes, now we can hear
Okay,
you.
so I with what we missed, I said we are clearly talking about health systems here. This was the first slide, and then we moved to this slide here, and I was talking about these 3 quadrants in the lower half of the graph, where I said we need a good system, needs to be accessible, provide good quality services, and then it contributes to improving population health outcomes. But in order to fulfill its maximum potential, we need to be clear what we say, which patients are really in need. And we talk about only conditions where a good health system can make a difference. We call this, and I come back to that, amenable to healthcare. And this is a subset of the burden of disease, so the overall disease burden in the country. And we start with this step 1. So what do we mean with disease burden? To actually get the burden of disease in a particular country or in a sub-region of a continent, in a whole continent or in the world. And if we look here at this arrow in the middle, so the assumption is people are born, and most people are born healthy. Clearly, some have inborn diseases where the partial health would start immediately, and those people who then develop one or more diseases, the idea is that they are in partial health, and some of them will die prematurely. In the Global Burden of Disease study, which collects these data globally, the life expectancy, so the optimum life expectancy is set at 86.6 years, and people who die earlier than that die prematurely, and we can then measure how many years of life are lost due to premature mortality, while those people who don't die and who are still alive, we can count the years lived with a disease or a disability, and this will be influenced both by the duration of the disease and by the degree of disability. So if you have a minor disease, the loss will be smaller for a given year than for a more severe disease. And then we can compare this over time. For example, I've taken examples from Ghana here because I assume many participants will be from Ghana, but data are available for all other countries. We can see, for example, that the disease burden for those people with the disease has been stable in the last 30 years, while for the premature mortality there has been a decline of about 50%, so that the overall burden of disease ratio between the first part here marked in blue and the second one has changed from 1 to 6 to 1 to 3. This is only the aggregate number. We can then break this down and look at what are the conditions causing most burden of disease. We start here with conditions causing the largest burden of disease among those living in Ghana. And I have the 1990 on the top part and 2019 on the lower part. And the global burden of disease study is dividing the diseases into 3 big categories. The one marked in blue are the non-communicable often chronic diseases. The one in red are the infectious diseases and maternal and neonatal conditions, and the one in green are injuries. And we can see there has been a shift in the burden of disease in Ghana over these 30 years, away from the infectious diseases towards the non-communicable diseases. We can also look at the years of life lost, so where the burden of disease is caused through premature death. And if we take that, we see the same development, but still the diseases marked in red here, you see neonatal conditions, malaria, diarrhea, lower respiratory infections, TB and HIV as examples, that they are still responsible for the largest part on premature mortality. We have these two approaches to look at disease prioritization, and what we can also do is that we add them together. So because they are both measured in healthy years lost, we can add them together, and this is what it's called in the global burden of disease study, disability adjusted life years lost. We see, just to put this into context, over the last 30 years for Ghana, per 100,000 population, declined by about 45%. So the burden of disease has become smaller. We can then use the same approach as before and look at which conditions cause the largest burden of disease. Same 3 colors here, blue, red, and green. And again, here the same picture, only that this is now the combination, and the size of each of these tiles will show us which causes the most burden of disease. So, for example, neonatal is a pretty big tile. Diarrhea was by far the largest cause of disease in 1990, but has become much smaller, while other tiles have become larger. We also see here at the upper left-hand side here ischemic heart diseases, which have become more relevant over time. So we can use this here and see which conditions cause the largest burden of disease. But But we can also say, okay, let's concentrate. And we are in a One Health course here. We can also say, okay, we can look at diseases, but we can also look at the etiology. So we can say, okay, looking, and I've just taken one example here, infections due to pneumococcus. And pneumococcus is both causing lower respiratory infections, but also meningitis. And we can take this approach clearly for a range then of other conditions to see which infectious disease entities, but also which other, what we would then say risk factors, tobacco, smoking, alcohol, and so on, are responsible for what part of the disease burden. But this is only step one, as I said. So we quantify the burden of disease across a population, and then the next question is this amenable through healthcare, through the health system, including a broad view on the health system, not only care but also prevention. And we know that many conditions, a big part of the population health status, whether we measure it in mortality or deaths or life expectancy, is due to non-healthcare factors like the environment, lifestyle, socioeconomic status, and only to a certain degree to the health system. And this red ball here should say that from the overall gray rectangle, which shows us the burden of disease, we are looking for those bits, for those conditions where a good health system can make a difference. And this is what is internationally called avoidable or amenable mortality. So which conditions for which persons would not lead to death if the health system would be a good one. And the concept of avoidable mortality is now already about 45 years old. And it is based on the idea that the mortality from certain causes of death is collected, identified where death is avoidable according to current medical knowledge, practice, and public health interventions in a defined age-sex group of the population. You see here two front runners of this concept, Rutstein, 1976, and Charlton, 1983. Clearly, we need a consensus of what qualifies for this. And it's not static, because medical progress means that the list of avoidable conditions is increasing over time. And if everybody would have its own list, then it would clearly be quite confusing. Currently, there are two main lists available. The one is developed jointly by the OECD and Eurostat, and they combined their slightly different lists in 2019, and that is based on 45 conditions. And the second, often used list is by the Global Burden of Disease Study collaborators, and it's used for the so-called Healthcare Access and Quality Index, and it contains 32 conditions or diseases. And how well a country is doing in regard to these 45 or 32 conditions can be used as a measure of health system performance. So the lower the deaths from these courses, the higher the performance of that country. And some people call it avoidable, while other people prefer the term amenable to healthcare. This one is you get the graph, you can get the slides afterwards, and then this is also better visible here. This is the beginning of the joint OECD Eurostat list, just to give you an idea how how it is built up and which conditions qualify. So it starts with infectious diseases here, and you see that intestinal diseases are mentioned: tuberculosis, diphtheria, tetanus, polymyelitis, and so on. And in the latest version, the data which I have not yet shown because these were on 2019, but in later versions, COVID-19 has just been added as a disease which is preventable through vaccination. At least that the death of COVID-19 is then preventable. And you see below the infectious diseases, because this list is sorted by the ICD codes, we see certain forms of cancer where either early diagnosis, screening, or treatment, or both can make a difference. And further down, we have ischemic heart disease and other disease entities. Those people, and I come back now to the healthcare view, which is not the focus of today, but just get us an idea here. I mean, also why the global burden of disease people call their index the healthcare access and quality index, because the idea is that those people with need, and the need would be at least visible, exist for these 45 or 32 conditions. And this differs clearly by socioeconomic status, as ethnicity, but also part of the world, so that these people need access to health services. And access to health services means that primarily you need coverage. And with that, again, we cannot go into this, but you are aware of the discussion of universal health coverage, because universal health coverage is a first and foremost condition to actually get access to healthcare. But clearly, it's not only important to be covered and that the service is covered, but that the persons living in a particular country or in a particular region, that they also have access to available services. So that's not only that they have an insurance card where they could get services, but that they are actually there, but also that the services are acceptable. If this is not the case, so if people have need, but do not get access to health services, we call this then unmet need. Those people who do not have unmet need, we say, okay, they can realize their access to health services, and then we can look in a second step on the quality of these services. There are data available, and again, this is not a course on health system performance assessment, but I just want to make us aware that for a complete picture, we not only need the data from the Global Burden of Disease study for disease prioritization, but there are also data from questionnaires, in this case here from the Afrobarometer, where people have been asked whether they have access, whether that differs from rural to urban areas, or whether they have unmet need. So how many people did have conditions which should have been seen by a medical practitioner or another health professional, but people were not able to get access. And with that, I want to make us aware that then we can look at the combined effect of accessibility and quality if we take the data of the healthcare access and quality index. I show you here the latest results, again from 2019. And this index is scaled in a way that the country which would be the optimal provide optimal care for these 32 conditions would get a rate of 100. So 100 is the best here, but we see that in real life the best performing country is only in inverted commas reaching 96.7, and the worst country is at 15. At 15.2, meaning that on average it's 85% away from the optimum country. And we can see here the countries of the world. The one in purple are the best ones, then blue, green, and the ones in dark red are the worst performing countries. We can, because it's based on these 32 conditions, we can go into details then. This detailed list here is from the previous edition based on 2016 data. And this is just a range of countries here, which I took from the middle of all the countries. And we see here it starts with Tajikistan ranked 121, down to Ghana ranked 153rd globally. And these are these 32 conditions. So it starts here with so the first one is the overall result. Then it is here tuberculosis, diarrhea, lower respiratory infections, upper respiratory infections, diphtheria, and so on. And you can see certain bits are marked in, also for Ghana here, are marked in blue, for example, how well it regards in respect to mortality from diphtheria. But there are also single digit numbers here. Here is, for example, 4, and 4 means it is 96% away from the best scoring country in the world. This one is on Hodgkin's lymphoma. So basically, is information available how well countries are performing in regard to conditions where a good health system can make a difference. So this is also available, and there are data, and this is not on individual countries. It's also available in individual countries, but this one is here is a cross-sectional table looking at the change in healthcare access and quality over the last 30 years between 1990 and 2019. And it looks at various levels of social economic development here. These are not identical to the World Bank groups, but roughly. So there is high social demographic index down to low. And it also looks at whether certain groups of the population by age groups benefit from or have benefited from a better health system over the last decades. And we see here the most progress has been made into the low to middle income countries, while the least progress from a already high level has been made in the high developing countries. But then we also see that most progress has been made for the younger population. So we see that in all socio-demographic country groupings, that the older population has not benefited as much from better health services, and therefore, and this is already the end. What I wanted to show you here, and where I see that we have enough time for discussion, is that we have different ways to prioritize diseases. We can look, or we can identify conditions which cause the greatest disability for those alive. We can identify those which cause most years of life lost, or we use a combination of both, this quality concept. We should concentrate in any case, because this is about the health system, on those with need. So we need a link between the burden of disease and the potential contribution which the health system can do. And or we can then look at where we still have poor outcomes. That was my last idea here, that we see where progress has been actually made, for which age groups, but also for which conditions, or where there is still big potential. Because if you can see that, oh, in my country we are for Hodgkin's lymphoma doing very badly, then clearly there is good reason that you should prioritize this disease higher. for all approaches, no matter which approach we use, we clearly need good data. And I often hear that people say, yeah, but we don't have the good data. And yes, the global burden of disease data are partly estimates, because good data are not available in any country, but it's a very good way to start. And then clearly prioritization is not enough. It's not enough to then say, okay, we should prioritize on these and these conditions, because then you need to identify ways to improve the situation. And then we are back to the question how to improve the access to health services and how to improve the quality of health services. And potentially we have in another course, live or virtually, also the opportunity to talk more about how you can improve the health system. These were my thoughts here on how to prioritize diseases for One Health, but also for healthcare in general, making best use of available data. Thank you, and sorry again for the technical problems. Verena,
Sorry, once again, I was muted. Many thanks, Professor Busse, for all these interesting insights. I think the participants need to digest all this information they've just received from you and from Dr. Quentin. So shall we go ahead with questions directed to you, Professor Busse? Or no, now Wilm is also here again. So maybe I start with Wilm. I think what we've all learned during the last years of the pandemic, that there were many global health lessons for all of us. And I think Wilm has very well explained that none was more important than the necessity of building health system resilience at both the national and international level, to safeguard against these devastating effects of pandemics. But now the question would be, maybe you can go back to your the framework with the shock cycles, because sometimes you were a bit interrupted and I'm not sure if everybody understood everything well. Maybe you can show with some examples where some of the countries are at the moment and what they are doing in the learning and recovery phase, for example, at the moment. Maybe you can provide some examples to the audience.
Should I go back to my slides?
Why not? Maybe we can, if we can have a look at
if there was,
because at the beginning was a bit interrupted with the connection and we received the feedback that would be interesting to have. Yes, thanks.
Yeah, I'm very sorry for the problems with the connection. I don't know what the problem is. I'm sitting in the middle of Berlin. I would have thought that my internet connection would be good enough. I'm sharing the slide again with the shock or disruption cycle. And your question was about where we are currently in the shock and disruption cycle. And clearly we are now in the recovery and learning phase after the pandemic, and where basically I would say preparedness of health systems to shock was, of course, before it was in 2019. The shock onset and alert was then in early 2020 for most countries. Shock impact and management took most of 2020 until 2022, and we are now mostly in the recovery and learning phase. China may still be slightly in the shock impact and management phase, but I don't really know where exactly they are, also because information is maybe not so available. But most countries in the world are really in the recovery and learning phase. And we are now all in particular, the learning is now important, and I think this course is part of the learning phase, and all the reports that I have shown as part of my presentation are related to this learning, where at the global level organizations are discussing concepts, how to build more resilient health systems, what the products can contribute to preventing this and to improving results. And back again.
Berlin has very bad internet.
It seems. I'm sorry.
Now it seems to be better again, but we couldn't understand the last words of your sentence.
So the last words were really related to that, we are all trying to now learn the lessons from the pandemic, and the reports of the World Bank, of the World Health Organization, of the OECD are all part of this learning phase at the global level to learn from the pandemic how to build more resilient health systems and how to better prepare for the next shock to health systems. And shocks can, of course, be also other events, not only pandemics, but these shocks could be financial crisis, they could be earthquakes, they could be environmental disasters, various floodings that are shocks to the health systems wherever they occur.
All right, many thanks. We have received some questions from the audience, and one of the questions was, I direct these questions now to both of you, and both of you feel free to answer them, please. One question was, are there existing One Health surveillance systems? And if yes, how do they work?
So a One Health surveillance system would really integrate surveillance of animal diseases and human diseases, and integrate the information within one database and provide it to decision makers in the country that they can access directly through the institution access to take decisions on the basis of this information. And I'm not a specialist in fact surveillance systems, and I hope that over the next few days you will get more information on surveillance. And I see that there now seems to be a problem with videos again. Is it my connection or is it?
Yeah, I think it's your connection.
It's my connection.
Yes, it's sometimes again interrupted.
I mean, I'm not aware of any comprehensive surveillance system. I think we also in an earlier part for the One Health development. I was just going into the human health thing with the global burden of disease study, and even there, it's complicated enough to quantify the impact of different pathogens, different risk factors on human health. And I think it will be also a challenge, but clearly a worthwhile challenge, that we quantify the impact on animals and on nature in a dimension similar to the impact on human health, to really see where the size of the problem is, whether the size is more on the human health or on the animal health. But again, I'm not aware of any specific system yet in place.
I could quickly add, Farina, if I may, that Thursday's lecture, as Vilmos already alluding to, will be about the One Health surveillance system, and mainly the animal and human surveillance system, which will be delivered by Professor Benjamin Enipe. And he will also share some of these challenges that Professor Buse had already outlined. And he comes out also with his practical experience or experience across the West African region, looking at the animal health systems and then also surveillance system, and then also how best perhaps to integrate that with the human surveillance system in the concept of One Health surveillance system, as Professor Buse had alluded to, that currently perhaps it's difficult to really come up with that concept. Yeah. But I have a question for Prof. Buse before, fair enough, maybe we continue with the comment that is it possible to apply the various concepts that are utilized to analyze human health systems also for example, animal health systems or veterinary health system? From where you sit, are these concepts applicable?
Well, as I said, I mean, it would start with quantifying the impact of what we in human health say these are risk factors or the etiology of diseases. And clearly we have certain risk factors, let's say climate change, which is a risk factor not only for human health but also for animal health and planetary health in total. Clearly the measurement scale which we have developed in thinking of years of health lost, either in people who are still alive or people who die prematurely, we would need to find a similar measurement scale for the other parts of planetary health, and because we have this idea, okay, how many healthy life years are lost per 100,000 population? If we take the impact on, let's say, climate change on trees, probably we say it's not the same dimension of one person and one tree. But I think it's worthwhile to think, first of all, of quantifying the impact on non-humans in a similar way, and then we still need to then see how we quantify the dimensions. Shall I take this question on the amenable to healthcare thing there, which I see from
Yes,
Karen?
please.
I was just thinking about addressing this question to you, so please go ahead.
Yes, I think, I mean, it's again, I try to say that we are not thinking only of people who are really ill, meaning they're about to die, from those who are less ill, further away from death. But there's this amenable to healthcare concept really says, okay, we have certain conditions where a good health system can make a difference. And let's say take diabetes, for example. People should not die from diabetes. If they die from diabetes, let's say this is the insulin dependent diabetes, we would assume either the condition has not been diagnosed or not the correct treatment decision has been made. So even though the person needs insulin, it has not been prescribed, or the insulin the disease has been detected, insulin has been prescribed, but it's not available, or the refrigerator chain has broken down. And so if people die from diabetes, we would say there is a problem in the health system. Clearly, we need, and I've glanced over it as you rightly noticed, the concept also needs, besides concentrating on certain conditions, also needs an age limit. Because if a diabetic dies at age 97, for example, we would say there is no premature loss of life. So conditions which lead to mortality at very high ages are then excluded, because we have the idea that amenable to healthcare means that people have not reached their optimum life expectancy. In many of these amenable mortality concepts, therefore, an upper age limit of 75 is used. I would think we need to revisit that probably at some stage and say, okay, is a 75-year-old not also still dying too early? But all this depends on our definitions of what we would say is a full healthy life, which somebody has expected. So it's the decision which causes of death are included. And I said that the list has just recently been added, has just recently been changed, that COVID-19 has been added, and it needs an upper age limit. I hope this explains your or is helping you to understand the concept.
Many
And should I
thanks.
take the question on ring fencing budgets?
Yeah,
Yeah.
so for Wilm and Reinhard, there are no moderators needed. They simply go ahead with the questions on their own. So this is nice. I just shall I read out the question again, directed to Wilm Quentin? So it's about the question was whether there are instances where the progression of the shock disruption cycle is truncated, and what do we do as healthcare providers to how to move along?
Oh, I was expecting a different question, but this one,
Yeah, so
because I'm
there are
not
two of
sure.
the
In fact,
questions.
I understand the question. What is meant with truncated? So where probably the question means that the shock is in the cycle is somewhere, and it doesn't from managing and dealing with the shock to recovery and growing from the shock after the shock. If that is the question, then, and it refers to what healthcare providers can do. And I think there the question is how far are healthcare providers able to respond to the shock and to change their way how they deal with the patients, how they measure whether it's possible for them to use different resources to treat the patients, whether it is possible for them to increase the availability of staff, to increase the availability of finances, to reallocate, to shift the tasks from certain to other stuff, to different to streamline the flow of patients in the organization. And I'm fearing that I'm breaking again because the videos showed something weird, at least on my screen.
Yes, unfortunately, you were interrupted several times. Maybe we can give it one more try and you repeat what you just said. Hopefully the connection's better now.
My assumption was that the question is asking if it sometimes happens that the shock doesn't move from the stage where the shock is felt at the provider level to the recovery and growth level after the shock, really. And if that is the question, it really depends on how the providers and how the system goes from absorption to adaptation to transformation. Basically, the first stage absorption is not sufficient. The system cannot deal shock in the way it is usually working. Then it has to change, to adapt, to use its resources in a different way, to use healthcare staff, to use different stuff to do the same things, to reallocate tasks and to reallocate resources. And ultimately, this is not enough. That it will have to transform its functioning into the structures to use to build additional resources to train new people to really be able to respond in a different way, in a transformative way to the crisis. It doesn't work?
Yeah, you were breaking for most part of it, but maybe you can also take the ring fencing question and add to it.
About the ring fencing. The ring fencing refers to the making resources and to protecting resources from other purposes. So basically, if there are legal provisions that a certain proportion of resources would always have to be used for pandemic prevention, would ring fence these resources from being for other purposes. This was specified by law in order to protect the resources from other purposes. And now I'm seeing only Professor Bussell. Is not our connection, somebody else?
Professor Buse, if you would like to also touch a bit. Yes, Bill. Yeah, we didn't hear most part of your submission, but Prof. Buse, if you could also maybe touch on the ring fencing question, just for purpose of rehashing what Bill might have said. So the question is, what ring fencing budgets, as it relates to the strengthening of health systems resilience, look like?
Well, I mean, the thing clearly, one issue is, and in many countries it's used slightly different at least when it comes to the level of ring fencing. It's a term often used also in tax financed systems, so where people pay general tax to the government, and then clearly the government or the parliament, depending on your system, how the country works, can then use the money according to its budget plan, its priorities. But whether then people feel that it would be good to ring fence certain areas, let's say health, that of $100 in tax money, at least $20 are used on health, so that it is protected from changing majorities in parliament. And in that sense, it would create a situation which is more similar to countries where the health funding is separated from tax money, because they have social health insurance contributions, and where people know this part of my monthly deductions from my salary is going to health. It becomes problematic if the entities for the ring fencing become too small. So if you say, okay, it's not only health is protected, but within health, a certain bit is protected to go to hospitals or to other things, because then it creates possibly unnecessary ring fences where progress, also that healthcare provision can become more on an outpatient basis, are hindered by the fact that hospitals have a sure part of the budget. So it really, whether it's useful, depends on where you ring fence. And if you have ring fenced everything, and then a pandemic comes, you don't have any money maybe left to spend on the pandemic. So some flexibility is always good. On the other hand, if everything between departments, Department of Health, Defense, and so on, is always open, then there might also be have its downside. So it really depends on the degree of ring fencing and whether there is any flexibility left to make changes because priorities or conditions have changed. Anything else? I don't see the questions anymore somehow.
There could be one of two reasons happening here. Either everybody
Yeah, I was
understood
also
clearly.
looking into our comments,
there they
but
are.
I think, sorry, now everybody is talking.
Go ahead, Ferdinand.
Daniel, please go ahead.
Okay. So I was saying that there could be one of two reasons, or two things happening. Either everybody understood the presentations and the discussions so far, and the answers are well clear to everyone, or that people still didn't understand. But we have a question. So where One Health approach has helped in shock management, if there are instances in terms of case studies that one could reference. And if there are, the question would be, at what stage of the shock or disruption cycle is One Health most applicable?
I guess that is a question to me, and that refers, I
Yes,
think, to
especially you
the.
handle the strategies. Yeah.
I think that refers to the last part of my presentation, where maybe I was breaking a bit and where a bit quickly, but the idea is really that One Health strategies are mostly useful in the early stages of the shock or disruption cycle. So they support the prevention of pandemics, and that's what I wanted to highlight, that taking One Health approaches are important to prepare, to prevent that in fact the shock is happening, and then they are important through the One Health surveillance system and a bit more for a bit more time. I've read several studies reporting on One Health surveillance systems, for example, in Thailand or in Kenya, that have been set up, but also in Canada, where there are more the attempts to really detect outbreaks in animals and humans and in the interfaces, and to have specific surveillance sites where on a systematic basis samples are taken from animals in order to prevent that that they, like, before they spill over to humans, or to detect them early when they have spilled over into humans. And this is really where One Health approaches are most useful, to early detect our shocks and to minimize the effect that these shocks or disruptions will have on the system by early interventions. Was that audible?
For most part of it, but still a bit breaking. But yeah. Maybe whilst we're waiting for other questions from our participants, perhaps we just signpost into what tomorrow will be talking about, which would be on the interactions between environmental, socio-cultural factors, as well as looking at risk communication and public engagement, as also some of the tools that or mechanisms that are used to bring about or implement One Health strategies tomorrow. Yeah.
Okay, Daniel. I mean, think either
if
you
there
have
are
more questions, or we call it a day.
Yeah, we were just going to ask
I
of your
just
final remarks.
Yes. If there are no more questions, we would be looking forward to your final remarks for this session, please.
And who should go first?
We could hear you very well. Maybe we should take the chance and you go ahead.
Yeah. I think, in fact, it is like preparing for this talk. One Health in combination, and I think resilience and One Health are linked really through, or One Health approaches can play a role to strengthening resilience of health systems in particular. And I think this last question was really good in terms of asking where One Health approaches most useful in the shock or disruption cycle. And my answer, if it was not audible, is that One Health approaches are useful mostly in the early phases, the detection, the early detection of shocks or potential events that spill over from animals to humans. I'm fearing I'm breaking again, but they can potentially also play a role in providing more flexible resources if, for example, human resource capacity that is available in the more animal health veterinary sector is also used in the human sector. And there have been examples of this, for example, veterinarians have been deployed to during the pandemic, or where laboratory capacity has been used to also analyze human samples. So I think One Health and resilience can be linked and should probably be conceptually much more linked than they have in the past. Thank you very much.
Maybe I add a few thoughts here. I think we are, coming from medicine, healthcare, we are all aware that we as a
Now we hand
profession.
over to Professor Busse.
Oh yeah, thank you. So, coming from medicine, healthcare, we are all very well aware that the medical thinking is often very individualistic based, and that even concept that as public health have it already difficult to be integrated into the thinking. And then expanding from public health to global health to One Health to planetary health, we are also conceptually only at the beginning. When I was preparing for my presentation today here. I went, as you saw, back to the global burden of disease study, and I should, when you go then to risk factors or etiology, it's still also a very medical based thing. It is already public health, but it's not One Health. So, for example, when we heard yesterday that One Health is relating to the concept of zoonosis, diseases coming from animals to humans, you cannot click because nobody is collecting the data yet. How big is the impact? And so when we talk about concepts, and that was my first remark and should be my last one, that concepts and data clearly are very much dependent on each other. We can only collect data and better understand the size of the problem, let alone then to develop solutions. If we have thought in the first hand that it is a problem and that we want to use it in our concept. And I think that is why this course also on the One Health thinking is so important. We need more people who think in these lines to then be better able to understand the problem. But to understand the problem, we also need to collect data, and we only collect data if we see it as a problem.
And this fits very well to the very last question we've just received. And this question is about looking at the dependence of humans and animals. And the person is questioning, what role does the layperson play in safeguarding One Health? Or is it entirely left to health professionals to react if the situation develops?
I mean, this is clearly a question going beyond the scope. I mean, even within health systems, we are often thinking that it is mainly for professionals, but we also understand that not only health itself, but also the concept of good health systems to find out what really which I glanced over when I said responsiveness is not so important to today, but clearly the perception of the population is the health system doing a good job is also very important. And when we then move to One Health, we also need to create an understanding of the size of the problem. And I think there are good in inverted commas allies now with the climate change, that people are thinking, yes, climate change is not only affecting our climate, it's also affecting really my health, because we have floods. I'm endangered by floods, but the floods are also endangering animals and so on. And then while the individual only can make a limited progress as an individual by putting pressure on politicians to really address these issues, it's everybody's business, because the health professionals are only the repair persons here, and we need the whole prevention thought has to be, at least especially from the One Health standpoint, given more visibility.
Wilm, do you want to add something?
To my presentation, at least, there would be also two comments. On the one hand, community engagement was one of the important elements that need to be strengthened in order to strengthen resilience of healthcare systems, because the relationship and working with communities, with people, with lay people, and making sure that they react and respond that is aligned with policymakers from health professionals, the shock, whatever the shock is really important in order to overcome the shock and to respond to crisis. And on the other hand, from the One Health perspective, also the role, the involvement of how individuals interact with animals, how communities behave and go into forests, eat wild animals, and all these interactions is an important part that contributes to diseases over the ocean is an important aspect of One Health that needs to be strengthened. Breaking again. This is so frustrating.
Yeah, but I think pretty much we got the point where you talk about the fact that human, eating wild animals, etc., also needs attention. So I guess we could relate to what you were speaking about or talking about. Yeah.
Okay.
Well, so I think we're at the end of our session of today. We've answered all questions, but if there are more questions, you can approach us via email, of course, or if these questions come up during the next days, you can post them as well. We will have a look at them. And we would like to thank Professor Busse and Dr. Quentin very much for their input today, for the availability and for the contribution. And we're looking forward to the other upcoming days of more input concerning the One Health approach.
Thank you very much.
And to
Okay, thank you.
also add briefly that yes, we have the Friday question and answers and the wrap-up session. So like Verena said, if there are more questions coming up, there is still opportunity on Friday to have those questions addressed. So yeah, thank you very much, everyone, also for your participation. And we continue tomorrow, same time, 4 p.m. GMT to 6 p.m. GMT. Bye-bye.
Bye-bye.